Um, we will begin a poster presentation. We welcome you all to the e-poster presentation track 2. I would like to welcome our judges, Dr. Soumya Satyendra, Professor of General and Obstetric Medicine, Associate Director, CMC Fellow, Dr. Sudha Jasmine, who is a Professor and Head, Department of Medicine 3. The rules are as follows. Each presenter is allocated 4 minutes and the video will be played. The presenter is available live to answer the questions. After the video, 2 minutes are allocated for discussion and questions from the judges. The questions from the floor and virtual participants will be taken only if the time permits. The recipient of the Equity in Health Presentation Award will be announced on the final day of the conference. I would like to hand over the session to our moderators.
Thank you, Dr. Anuka, and it's a privilege to be here, and we're looking forward to listening to all the presentations, and we'll go from there. Please, we can start the program.
First, we'll have Dr. Venkatachalam Viswanathan. Dr. Jairam, can you just mute our presentation?
Good afternoon, everyone. My name is Dr. Venkatachalam Viswanathan. I'm doing the second year postgraduate in the Western Maharashtra Medical College in Sarjapur. My topic is the whole clinical control. Coming to the background, and if you all know, parental and medication that is common in DPC and partial details. This game is going to be convenient, but however, it comes to using the therapeutic tools because of non-in small piece of tools can cause market sizing, plasma concentration, toxicity. Nowadays, this is only used whenever the new drugs are not tolerated. Some of the common effects of Phenytoin are nausea, vomiting, hypotrophy, hypertension, and fetal hydrated syndrome in pregnancy. In case of toxicity, can lead to cerebellar and vesicular manifestation, toxicity, content, behavior pattern, mental conflict, we have a case in our body that 68-year-old female with the main cause of period disorder on uterine cerebral hungary period. And also one case of RP status for people not a medication. 8 complaints of involuntary movement of all 4 limbs with the decreased food intake fever for the past 1 day. On examination, patient was skated, restless, afebrile, monthly stable, but GCS was equal before M5 and 13 by 15 equals the repeat to night. Next stiffness was present until doing all of 4 years and cancer cells are withdrawn. Patient initially initial diagnosis on test septic or metabolic encephalopathy, and we are empirically started on antibiotics and antiseptics. Initially, cardiology opinion was sought and 2D report revealed RLT moderate MS with normal release systemic function but low clot indication. Later, a psychiatric opinion was sought and the patient was diagnosed as difficult disorder started by non-testing. Neuromedicine opinion was sought for which MRI brain was done and found very normal. EEG also was done and found very normal. And suspicious of being viral or bacterial meningitis, lumbar puncture was done after only was black blood edema, which is also found to be normal. Hence, after only got all the metabolic and infectious causes, we have arrived at the diagnosis suspicious of Phenytoin toxicity, for which we assessed Phenytoin levels and found to be greater than 40 micrograms. An authority was not an advice for hemodialysis. After total 3 cycles of dialysis were completed, the Phenytoin level were decreasing and found to be around 59 micrograms per deciliter. Over the course of hospital stay, patients' cognitive function have significantly improved. Post-necrosis, patient has given us a history of intake of 12 tablets of Phenytoin 2 days prior to admission. Conclusion, this poster emphasizes the importance of vigilant monitoring and timely identification of toxicity, especially in such patients with atypical presentation etiology after ruling out all other metabolic and infectious causes, which helps in full recovery with the right medical support. Thank you.
Check, check, check. Venkatachalam, thank you for that
Yes, ma'am.
presentation. Just wanted to ask you, what were the features of phenytoin toxicity that you saw in this patient?
Ma'am, we couldn't see any features of gum hypertrophy, hirsutism, or any such features, ma'am. Only presentation which she came was altered behavioral pattern, ma'am, for the past 2 days.
So what other features of phenytoin toxicity can you expect to see in a patient who has taken a higher dose of phenytoin? Even in a patient with altered sensorium, there are certain findings that you might check for, right? So
Yes,
was
gum.
for gum
Uh,
is an effect of chronic ingestion, not of
okay.
acute toxicity. What features of acute toxicity did you see?
Hirsutism. And,
Again, hirsutism is an effect of chronic ingestion of phenytoin, right? Whereas with
Mm.
acute, did you look at the eyes? What were you checking for?
no, ma'am, we couldn't find any fundus examinations found to be normal.
Did you happen to look for nystagmus by any chance? Was there anything to suggest ataxia? Because you did talk about it as cerebellar manifestations, right? And that is what happens when you have acute toxicity. So
Okay.
when you look at the eyes and if you find nystagmus in
Okay.
somebody who is coming with having taken phenytoin for a long period, then
Okay,
you
ma'am.
know whether there is something like a toxicity, because it can happen not just with overdose ingestion, it can happen even with drug interaction with something that can inhibit phenytoin's metabolism, or when there is something that is added in that will affect the cytochrome 450, then you would kind of get this toxicity. So even drug interactions can lead to, or even if people who are at 68, if they're accidental, they may forget. If they are forgetful and they take medicines, they could have that unless they're having regular monitoring. So it's important to look for nystagmus and ataxia in a patient like that. Why did a patient who's 68 take overdose? Did you explore?
Ma'am, she was actually a neglected patient, ma'am. After 4 days of admission, only we found that she was diagnosed with depressive disorder. Because of that only, she had taken 12 tablets. She had no specific reason.
So, good presentation, Venkatachalam. Just more question. After you
Okay.
presented and you've dealt with this case yourself, what are two aspects of history that you would have liked to have asked? Which you may have found later. Any other thing in the history that you will add on that you could have asked the patient even before all the tests were done, which would have helped you come to your.
We asked for any drug overdose initially itself, but we couldn't arrive at a point because she was also an altered sensorium, and her daughter also had. No, she couldn't. She was not able to come to that point.
Anything else? Patient has other comorbidities, so anything else that
Any other drug interaction which could have decreased the phenytoin metabolism, but she was not on any other drugs. She's also a known case of RHD, but she was not on treatment for that. Apart from that, she didn't take any other drugs also.
So that's good. So one is the drug history, and of course, you did say you asked for overdose. One suggestion sometimes if people come in with multiple tablets or even single, is to ask the relative to bring the empty packets. Just bring us the what they use, the bottle or something like that, so that you can do a count. So thank you so much. Thank you for your answers.
Greetings to everyone. Myself, Dr. Deepika. The title of my study is Prevalence of Co-Morbidities Among Persons with Disability aged 18 to 59 years in the area of Sarjapur Primary Health Center, a cross-sectional study. According to WHO, disability is defined as any restriction or lack of ability to perform an activity that is normal for a human being. The global burden of disability is about 10 to 15%. According to Census 2011, there are 8 types of disabilities, that is disability in movement, seeing, hearing, speech, mental illness, mental retardation, and multiple disabilities. A comorbid condition is an additional condition independent of and unrelated to primary condition. Some of the examples include hypertension or diabetes in a person with intellectual impairment. General morbidity is high among persons with disabilities. They can't access healthcare due to various barriers and hence lies the inequity. To overcome this, health system should make adequate provisions to improve inequity by providing either door-to-door healthcare services through ANMs or make healthcare facilities accessible. With this, the objective of my study is to assess the prevalence of comorbidities in identified adults with disabilities in the age group of 18 to 59 years in Sarjapur PHC area. Moving on to the methodology, this was a cross-sectional study done among adults with disabilities in the age group of 18 to 59 years residing in Sarjapur PHC area for at least 2 years. Any treatable causes of disability like cataract were excluded from the study. Due to lack of published articles on comorbidities among persons with disabilities in India, the prevalence of any comorbid condition is taken as 50% and hence the sample size was calculated as 100. First, the adults with disability were listed village-wise using HMIS. Then the study group was selected by stratified random sampling based on each village considered as one's data. Then the study group was selected by probability proportional to size to number of persons with disabilities residing in each village. Then the study group was selected using simple random sampling from the list of adults with disabilities. The study tools used were socio-demographic details and the comorbidities assessed were hypertension, diabetes, anemia, obesity, seizure, asthma, and tuberculosis. Coming to our results, about 56% were males, but 31% were in the age group of 18 to 28 years. More than half of the participants had disability in movement. A total of 95% of the study subjects had comorbidities. There was a significant association between age and hypertension, where hypertension was more in the age group of 40 to 50 years. There was no significant association between gender, socioeconomic status, and education with hypertension and diabetes mellitus. Females were more anemic compared to males, and this was statistically significant. Coming to a discussion, about 17% were hypertensive in our study, the reasons being low prevalence of tobacco consumption and obesity. About 28% were diabetes in our study, the reasons being sedentary lifestyle, low levels of exercise, and probable consumption of high fatty diets. About 39% were anemic in our study, which is almost similar to one of the studies done in Japan among intellectual disabilities, where the reasons being poor intake of iron-rich food, high prevalence of vegetarian diet, probable worm infestation, and poor personal hygiene. About 12% were overweight in our study, the reasons being high calorific intake, less physical activity, excess use of medication, lack of dietary advice, and lifestyle changes. Conclusion, a total of 95% of the study participants had comorbidities, 28% were diabetic, 17% were hypertensive, and about 39% of the study subjects had anemia. Recommendations: to promote health and well-being, yoga, meditation, and daily exercise should be stressed. Health education on balanced diet, preventing the consumption of alcohol and tobacco should be given in the formats that are accessible to all types of disabilities. To tackle malnutrition, Panchayat should procure rations from public distribution system and provide to persons with disabilities. Periodic general health checkups and screening at regular intervals should be done to identify the risk of non-communicable diseases and its complications. These are my references. Thank you.
Thank you, Deepika. That was an interesting study looking at a population that's not looked at much.
Thank you.
Welcome. So I just wanted to ask you that what were the spectrum of disabilities that you were looking at? I know you looked at the comorbidities, but what was the spectrum of disabilities? This is a younger age, I understand, 18 to 59. So what disabilities did your patients have?
We had disabilities like disability in movement, vision, hearing, and some of them even had multiple disability.
Okay, because it may have helped to look at the comorbidities in relation to the disability, because obviously some are fully dependent, on what is given to them. If they have no vision or if they're, legally blind, then it kind of correlates to what you have said. So what we have is just a association, but we don't know if there's actually, we just know there's some connection, but where it's actually valid, we don't know. We get the point about the comorbidities. Most of these people were living with family, or who were their caregivers?
Yeah, most of the participants, study subjects were living with the caretakers. For a married person, either husband or wife was the caretaker, and for majority of the study subjects, their parents were the caretakers.
Okay. Would that mean that they were unmarried? Was the disability a reason for them not marrying? When you said parents were caregivers, I know between 18 and 59 you can marry as per the law. So I just wanted to ask.
Nearly 50% of the study subjects were married in my study, ma'am.
15, is it? 15?
50 were married.
So what about the gender of, your patients, your group of patient studies? Were they more men or women? And
majority were men, ma'am, males in the study. About 56% were males.
Do you think there's any cultural context that will, as you said, the practices, lifestyle practices, be it food, exercise, all of that was a problem. Do you think there's any cultural context in which in India we would look at people with disabilities? What are your thoughts? And so contribute for all of the lack of things that you said, not healthy lifestyle and no diet. What do you think is a cultural context in India that would make somebody unhealthy if they couldn't feed them? Somebody else was giving them food. I think classically, culturally, women in India, food is the answer to most things. So
yes,
we say if you eat well, you'll be strong or you'll become well, irrespective of whether the disability is linked to food at all. So I think the cultural context and maybe a qualitative part to your study would have actually helped to understand why exactly didn't they have a healthy lifestyle. That's just a suggestion. I'll just give it to Dr. Sudha.
Thank you for that very interesting study, Deepika. I just wondered what is the percentage of undernutrition in your population?
Ma'am, undernutrition were about 12%, ma'am.
Okay, and overweight was a larger percentage.
Yes, ma'am.
Yeah, I guess the lifestyle, if you have a disability, then trying to do an exercise or something else will also be impacted by that. So I think there needs to be a different kind of an approach there. Very interesting, thought-provoking studies. So thank you very much.
Thank you, ma'am.
Good morning. I am Manna Elizabeth Winford, and I'd like to present my research on incidence, causes, and feto-maternal outcomes of obstructed labor in a secondary healthcare center in Prem Jyoti Community Hospital, Sahibganj district, Jharkhand. As we all know, obstructed labor or neglected obstetric labor is the leading cause of preventable maternal and infant morbidity and mortality, especially in a developing country like ours. The incidence of obstructed labor globally was found to be 3 to 6% and varied across the country. However, there is a lack of data from rural Jharkhand. Hence, our objectives were to study the causes, clinical profile, maternal and perinatal outcomes, and to identify the incidence of obstructed labor in a secondary hospital in Jharkhand. This was a hospital-based clinical observational study conducted in Prem Jyoti Community Hospital, located in Sahibganj district of Jharkhand, which is known to have a high maternal mortality rate and an infant mortality rate. The study was conducted over 18 months, and we included all pregnant women admitted with obstructed labor and delivered at our hospital. A pilot study was conducted and the sample size was calculated to be 62. We obtained the data using a structured questionnaire. Among the women who presented with obstructed labor, 19% of women were teenagers. 35% of the women belonged to tribal community. 50% of them were illiterate. Almost 30% of the women did not have a single antenatal visit, and 60% of the women did not have a single ultrasound done during their antenatal period. Almost 21% of the women had to walk over 1 kilometer to reach the road. 34% women had to travel over 30 kilometers to reach the hospital. 42% were unaware of their gestational age. 50% of the women stayed at home for over 8 hours before accessing healthcare. 50% of the women were at another hospital before being referred to our setup, among which 29% were admitted for over 7 hours in the first hospital. The incidence of obstructed labor was found to be 9.9% in our hospital, which is high as opposed to the other states in our country. And the most common cause of obstructed labor was found to be cephalopelvic disproportion, followed by malposition and malpresentation. Almost 61% of the newborns required NICU admission, and the perinatal mortality was calculated to be 16.9% with 11.2% early neonatal deaths. There were no babies that were large for gestational age. The most common neonatal complication was neonatal sepsis, followed by neonatal jaundice and birth asphyxia. The most common maternal complication was puerperal sepsis, followed by urosepsis, severe anemia, and postpartum hemorrhage. It was also found that among women who presented with dehydration and shock, they had a more incidence of maternal and perinatal morbidity and mortality. It was also found that higher cervical dilatation at presentation was associated with higher neonatal complications and mortality. Staying at another hospital, especially before being referred here, was associated with increased post-op complication, low 1-minute Apgar, and neonatal and perinatal morbidity and mortality. Illiteracy was also associated with a low 1-minute Apgar. Hence, to conclude, incidence of obstructed labor was very high, with a very high rate of maternal and perinatal morbidity and mortality. And this was mainly found due to various factors like illiteracy, poor antenatal coverage, teenage pregnancy, lack of proper referral system, lack of transport facilities, lack of emergency obstetric and neonatal facilities, lack of timely intervention, prevalent home births, and lack of awareness of obstetric complications. This highlights an immense need for equity in maternal and neonatal healthcare in our country. Thank you.
Good afternoon, Manna. Thank you for that very interesting but a very heartbreaking kind of a study. As you know, we both work in that ops med space, and yeah, looking at what you're dealing with must be so much difficult compared to what we deal with here. So thank you, because I think it's not easy to be dealing.
Thank you, ma'am.
Where you are. Having said that, how many of your patients were diabetics, Manna? Were any of them? Did you even have a
Most of them were undiagnosed. Like, this is probably during labor was the first time they presented to the hospital itself. So most of them were unaware of any comorbidities. And a few were diagnosed to have hypertension, preeclampsia. That is after arrival at the hospital. So none of them were antenatally diagnosed.
Yeah, but was the GRBS abnormal in any of them? But I guess
No.
They were all probably not starving during their time of labor if they were not eating well during that.
Yeah, the GRBS was normal for all of them.
So it's not your diabetics that's causing, it's the teenage pregnancy and they are built.
The contracted pelvis, I think, was the most common cause, and not diagnosing contracted pelvis antenatally. So because of poor nutrition during teenage puberty and teenage period, and also early pregnancy, and not diagnosing it antenatally. So that is what we found was causing the obstructed labor. And also the babies, none of them were large for gestational age. None of the babies.
All normal babies, but they didn't, because they were not diagnosed and they didn't have an LSCS, which they should have.
Yes.
A normal set.
And yeah, and also like almost 33% of women were short, less than 145 centimeter, which is a criteria for LSCS. So that also we could have prevented them from going into obstruction as well.
Hi, Manna, and thank you for what I'd like to ask is, you did mention that it's a higher percentage in the district or the state as compared to others. If you look at it, is it something to do with the phenotype of in terms of an ethnicity or a population who's shorter, so has smaller pelvises? Is there something like that? Any association?
Yeah, so initially I started the study because I thought that the Malto tribals, a part of them were short, and I thought maybe they are going into obstruction. But during the study, which we conducted at the hospital, which caters to the entire district, what I noticed is not only the Maltos that are going into obstruction, even the people from other tribes and also non-tribals, even they are going into obstruction. So mostly probably it's the food habits and the lack of nourishment in general. That is.
So that's very interesting because, as you said, you did look at the reason, and that's good. So in
Yeah.
terms of kind of health education to practitioners, if you look at people kept them long, people didn't refer them. Some of them are very
Yeah.
been mishandled. Any efforts to kind of educate? What have you been able to do as something of where we can help? Yeah.
Yeah, so what our hospital has been doing is, so this study was conducted during the COVID times where our mobile clinics for antenatal checkups had halted for a month or two. So we actually increased the mobile clinic access and started covering areas that were not accessed by the government, and conducting health education and mobilizing people to come to our hospital. Also, ultrasound, none of them, 60% women never had an ultrasound. So our aim was to get them to get an ultrasound done, at least one. And now our hospital has an ultrasound machine. So that we have improved on that. And health education during mobile clinic visits, we've improved on that. Only thing is the referral system needs to strengthen further, and the transport facilities still remain to be a problem.
Thank you for that, Manna. I'm sure you'll have tried, and it'll be interesting to see over a period of time with all of your interventions whether it helps to improve it. And I agree there are other systems which may be out of your control. But
Yeah.
thank you much.
Thank you, ma'am.
One suggestion, Manna, we do have
Yes.
ultrasound machines which are actually like probes which are just large, and you don't need to have
Yeah.
a large machines which are coming up. Just to explore
Okay.
whether you can take that on your mobile clinic. For those who can't
Okay.
in hospital, if you can take the ultrasound probe, I mean, just to explore that, contact Nalini or somebody to kind of
Yeah.
say what can be done, and more
Mm.
power to your tribe. I mean, fantastic work that you're doing there in your place.
Yeah, thank you, ma'am.
Thanks, Manna.
Myself, Dr. Ashish Kumar Jain from Gandhi Medical College, Bhopal, and the title of my study is tissue doppler imaging as a prognostic marker following a ST elevation myocardial infarction. The early diastolic velocity of the mitral valve, EDAS, reflects the rate of the myocardial relaxation, and when combined with the measurement of the early transmitral flow velocity, capital E, the resultant E by EDAS ratio correlates well with the mean LV and diastolic pressure. In particular, an E by EDAS ratio of 15 or more than 15 predicts a poorer survival after the acute ST elevation MI. Aims of these studies to analyze the clinical characters in hospital events in patients admitted with the acute ST elevation MI, evaluated by the echocardiographic color and tissue Doppler, E/EDAS ratio of the mitral valve as a measure of the LV filling pressure. To assess the usefulness of E/EDAS ratio as a prognostic indicator in the patients with the ST elevation MI with or without revascularization therapy. Methodology: transthoracic echocardiogram were performed in 256 consecutive patients within 24 hours after the admission for the acute ST elevation MI, and the patients were followed up until their hospital discharge. And the endpoint was all-cause mortality. As you can see in the table, the basic baseline demographic and clinical characters. Mean age of the patients were 54.9 years. Out of them, 82% were male, 25% of the patients were having hypertension and diabetes, 65% were smokers, 61% were having dyslipidemia, 22% were having CLIP class of 2 or more than 2, and 70% of the patients were admitted with acute anterior wall MI, and the 30% patients were admitted with inferior ST elevation of MI. Majority of the patients were having E/EDAS ratio of less than 15, that is 70% of the patients. In the rest, 30% of the patients were having E/EDAS ratio of more than 15. If we cross-tabulate between the E/EDAS and the deceleration time, the deceleration time correlates well with the E/EDAS ratio. When deceleration time was more than 140 milliseconds, E/EDAS ratio were less than 15 in majority of the patients, and when deceleration time was less than 140, E/EDAS ratio were more than 15 is majority of the patient, and the p-value were highly significant. Similarly, if we correlate E/EDAS ratio by mortality, the ratio was highly significant, and when E/EDAS ratio was more than 15, 34% of the patient died compared with the average mortality of 13.5%. And when EY/EDS ratio was less than 15, only 4% of the patient died. So the p-value was highly significant. Conclusion: EY/EDS ratio can be used as a surrogate marker of the elevated LV filling pressure, and hence can be reliably used as a prognostic marker to risk stratify the patients. Advanced diastolic dysfunction is associated with an adverse outcome after the acute MI, with an abbreviated DT being particularly predictive. The current data confirm the prognostic value of the DT. Thank you everyone.
Thank you, Dr. Ashish.
Yes, ma'am.
I can see a very useful study in terms of being a point of care kind of prediction, even before the enzymes come in. With the ECG, I think the E/E' can really help you.
Yes, ma'am.
Out of this, does it E/E' depend on the skill of the person doing the echo, or how would you predict? Because we have different people doing it. I know to a large extent it is already it depends on the person who's doing it. Does that make a difference? And who was doing your echoes during this? Was it doctor-led or technician-led?
Ma'am, I'm myself doing echo for my patients. And there are standard guidelines, ma'am, like where to place the sample volume for E and where to place sample volume for EDS. So, standard guidelines which were published last year or last to last year by European Society and American Society also. So, from that inter-observational bias, I think that is decreased probably, but that also depends on who is doing and where the sample volume is placed.
Is placed also to determine in a way, but it's a useful thing. The other thing is, you said affected mortality. Was there any other than the echo finding? Were there any comorbidities or correlations to people who had a prolonged E/E? Were they all more hypertensive? Was there anything else that could confound?
Ma'am, 25% were already having diabetes and 25% were already having hypertension, previously diagnosed hypertension, and approximately 30 to 40% of the patient were previously already have a CAD, coronary artery disease. So I think
that may end up, I don't know, may not have patients who we have echoes previously on to know how it has changed. That's just a thought. I'll just give it to Dr. Sudha. Thank you for your presentation.
Thank you, ma'am.
Thank you for that presentation, Ashish. Just wondering, what proportion of them got treated with what? I mean, was there a difference in the therapy that they got, or did all of them have the same therapy? Because
no, ma'am. Those who were in the window period, they were thrombolized, except if they were not having any contraindications. And since our centers do not have a facility for primary PCI, so we did performed PCI after that is late PCI. So some were performed with PCI and some were performed with only medical management. Continue.
So one of the, before you do those correlation mortality, would be good to adjust it to the therapy to see how many had PCI versus no PCI, and those who had hypertension versus adjust the ratios for the hypertension as well as the therapy before you kind of do that correlation for mortality. That will kind of give you more valid measurements to say, do they actually correlate with mortality? Because both hypertension will affect your E/E'.
Yes.
And your therapy would impact mortality. So it might be worth the while to look at some of those things and see if comorbidities were controlled versus not controlled. And those are some factors that might impact your mortality, which may kind of look different when you're looking at it this way. And say, is the effect really because just the E/E' ratio?
Okay.
Thank you very much.
Thank you, ma'am.
Next, Dr. Priyanka.
Good afternoon, all. Myself, Dr. Priyanka Bhaskar, second year postgraduate from Government Vellore Medical College Hospital. I would like to thank my HOD ma'am, Dr. Abhirami, Neuro HOD, Dr. Monica Vasatham sir, and Dr. Muthu sir for constantly enlightening me. Today I am going to discuss about a case which we treated at our hospital, treating aphasia and regaining communication. A rare case of Foix-Chavany-Marie Syndrome. Foix-Chavany-Marie Syndrome is a rare cortical form of supranuclear type of pseudobulbar palsy, which was first reported during 1926. Typically, it is described as loss of voluntary control of palatal, glossal, pharyngeal, masticatory, and oral muscles, but with preservation of autonomic and reflex movements. As such, production of speech, chewing, and swallowing are impaired. Most commonly occurs following bilateral opercular stroke. Here comes 56-year-old man who is a known case of type 2 diabetes mellitus, systemic hypertension, hyperhomocystinemia with left hemiparesis, with history of difficulty in using right upper and lower limb, inability to speak, and a history of deviation of angle of mouth to left, difficulty in eating food, drinking water, and history of altered sensorium present for past 1 day. On examination, patient was drowsy, arousable. His GCS was 11/15, right plantar was extensor. Paucity of movements is noted in right side. Patient was provisionally diagnosed as having recurrent CVA, right hemiparesis, and he was treated with intravenous crystalloid, antiplatelet, and statin. On next day, patient became conscious. Patient was found to be dysphagic, aphonic. Comprehension was normal. He was having right-sided facial palsy with power of 4/5. Pharyngeal palatal reflexes were present. Right plantar was extensor. Other systems like sensory, cerebellar, autonomic systems were normal. CT brain and MRI brain images were taken. Management included nasogastric feeding, chest physiotherapy, and to continue oral medications. Our case showed remarkable recovery. This is a relatively rare syndrome. It most commonly occurs following bilateral opercular stroke, can also be caused due to trauma, tumor, CNS infection, and other rare causes. Our patient brain MRI revealed both acute and chronic infarct in temporoparietal region involving middle cerebral artery, which appears to have contributed to this syndrome. The anterior operculum contains the voluntary motor fibers for 5th, 7th, 9th, 10th, 12th cranial nerve, which then travel to cranial nerve nuclei via corticobulbar tract. Injury to this area can cause Foix-Chavany-Marie syndrome, causing bilateral voluntary paralysis of facial, masticatory, pharyngeal, laryngeal, and brachial muscles. Prognosis for each patient depends on extent of lesion involved. This should be considered in patient presenting with acute onset anarthria with automatic voluntary movement dissociation. Opercular syndrome can be produced both by cortical or subcortical lesion affecting corticobulbar pathway involving cranial nerves. If it is diagnosed early and given appropriate management, patient could be prevented from further complication, and it will definitely aid the patient in having better survival. I'd like to share few video clips of my patient. Patient presented with drooling of saliva. Patient had loss of speech even though his comprehension was normal. Patient was not able to talk. After follow-up and with
Jyoti, Raja, Shanti. Amma. Ananya. Sandil, Kavin.
Thank you.
Thank you, Priyanka. An interesting patient. I'd just like you to, Priyanka, can you just tell us your clinical findings on examination again, please? Which you present.
Clinical examination on first day patient was drowsy, ma'am. So we could elicit only with the attender about the history, ma'am. Examination was having hemiparesis alone is present, ma'am. On the next day, patient was awake and jaw jerk is brisk and plantar is extensor. 4/5 was his power of the limbs. And patient is mute, ma'am. Literally, I found the patient was unable to speak, but his comprehension was normal and he was able to even write, ma'am. His voluntary movements alone is affected. Involuntary movements were present, ma'am, like yawning and laughing. All those emotions are intact, ma'am. But voluntary movements like chewing and swallowing are difficult for the patient, ma'am.
So in a way, it was bilateral that you found that on the presentation, on the clinical examination, it was a bit confusing in terms of you did find bilateral deficits of all of the cranial nerves involved. Did you find that, or it was like a diagnosis made afterwards? Because I thought it seemed more unilateral. Like, how would you differentiate it from, somebody with a stroke with Wernicke's? You said no comprehension, but you said he was also speaking. Yeah, with the comprehension, Broca's aphasia. Yeah. How will you differentiate it from a classical MCA territory stroke with Broca's aphasia? Can you hear me? Sorry.
Yes, ma'am.
Asking same question. Yeah.
Yes, ma'am. It mimics like a pseudobulbar palsy, ma'am. Broca's aphasia, motor component will be affected, ma'am. Motor component alone will be affected, ma'am. But for this patient, other cranial nerves also involved, ma'am. Like 11, 12, 9, 10, all those nerves are involved, ma'am.
Okay, and when he recovered, how many days later did he recover? I mean, when you felt he was
3 to 6 months he took, ma'am. He's mute for 2 to 3 months, ma'am. We sent back home the trials, ma'am, and we informed the patient to prevent aspiration, ma'am, and to continue the medications, ma'am. Patient literally followed all those, ma'am, and we could able to see the difference and also the recovery, ma'am.
Priyanka, just to ask, where was the hemiparesis when he presented to you?
Ma'am, chronic infarct was present and acute infarct is present in parietal region, ma'am. Before that, MCA, ma'am, actually now it is present in the left side, ma'am. Old infarct lesions were present in both sides, ma'am.
So is it a pseudobulbar palsy because the patient had previous vascular insults, or is it because it's a combination of deficits from the old and the new, right?
Yes, ma'am.
But this time she presented with a left-sided.
Old was left, ma'am. Old was left, ma'am. This side right was the presentation, ma'am.
Right hemiparesis.
So, right hemiparesis, ma'am. We initially diagnosed it as recurrent CVA, ma'am. But later only on detailed evaluation, we could find out this rare syndrome.
Okay, thank you very much. What did you do for that homocystinemia?
We gave folic acid and multivitamin tablets, ma'am.
Thank you. Yeah, thanks.
Thank you, ma'am.
Next, Dr. S. Nanban.
In this e-poster, I present you a case of subleukemic leukemia presenting as pancytopenia. Subleukemic leukemia is characterized by presence of abnormal white blood cells located in peripheral blood and marrow, but in which total number of white blood cells is normal. Clinical features are non-specific, which includes fever, fatigue, weight loss, bleeding, etc. Early diagnosis is vital as the disease carries high mortality. Here we report a case of 49-year-old male who presented with complaints of fever, myalgia for a week, and a chronic history of bleeding per rectum secondary to hemorrhoids. Lab investigations revealed pancytopenia. Hemoglobin was 5.7, total counts were 3,700, and platelets were 99,000. Peripheral smears showed atypical cells of about 28%. He was further evaluated with bone marrow biopsy, which revealed a leukemic blast of around 25%. The blasts were round cells with fine chromatin, with abundant granules, with 3 to 4 nucleoli, and with few rods as well. Cytogenetics revealed translocation of 821. He was diagnosed to be a case of AML and he was started on standard 7+3 regimen. Patient achieved complete remission, which was confirmed by bone marrow biopsy, which was done 2 weeks after chemotherapy, and it showed less than 5% of blasts. Patient right now is doing well and he is in post-remission therapy. Discussion. Subleukemic leukemia is diagnosed when total leukocytes were within normal limits, but peripheral smears shows few atypical cells or abnormal cells. The clinical manifestations of the disease is non-specific, which presents usually with fever, fatigue, bleeding, and the common causes of pancytopenia includes megaloblastic anemia, dimorphic anemia, hypersplenism, or infections, and the lesser common causes are subleukemic leukemia, aplastic anemia, and cytotoxic drugs. AML and ALL have equal incidence in subleukemic leukemia. Overall, the 10-year survival varies between 3% to 73% based on cytogenetics in AML. Hence, prompt diagnosis is crucial and treatment protocol involves chemotherapy, which reduces amount of apparent blood cells or promotes growth of normal cell lines. As physicians, we need to be aware of this rare finding of subleukemic leukemia in patients with mild constitutional symptoms. Early identification, prompt diagnosis, and early initiation of treatment are crucial as it results in better outcome for the patient. Thank you.
Thank you, Nanban, for that presentation. So what did you do for this patient once you diagnosed AML?
Ma'am, once we diagnosed AML, we started the patient. I mean, we referred the patient to a higher center, ma'am. There, they started chemotherapy for him, ma'am. Induction initially they started. They put him on 7+3 regimen, ma'am. They gave him, and then after 1 week, they redid the bone marrow biopsy. Blasts were less than 5%. So he was started on remission phase.
Given that you gave some differential diagnosis.
Initially, they put him on cytarabine as well as daunorubicin.
Thank you, Nanban. I just wanted to ask, based on the differential diagnosis you gave, on clinical examination, what exactly will you look for? There was no physical examination in your presentation, so I am asking. For a patient who comes with similar symptoms and this kind of pic in a CBC, what clinical...
Sorry, ma'am, I couldn't.
Okay. I'm just asking
Yes.
clinical examination based on the differentials you gave for someone with pancytopenia. What are the clinical features, examination findings that you will look for on physical examination?
We have to look for anemia, ma'am, because the most common cause for a pancytopenia that we routinely see is megaloblastic anemia. So that we have to look for anemia, and then we have to look for any organomegaly, ma'am, whether any splenomegaly or hepatomegaly is there for that patient. And
anything else with, because you said megaloblastic anemia, if the person is a vegetarian, has a B12 deficiency, you think any other specific finding in the skin? So hyperpigmentation over your knuckles, there are other signs that will tell you if the person has a megaloblastic, and a complete neurological examination will also help. So in a way, the clinical examination is obviously will be important. If you don't find anything on that, then we go to the labs, obviously, and go from there. So otherwise, a very interesting presentation, and I agree with you. We do get pancytopenia and general medicine, and we should be aware of our differentials. And the peripheral smear, I think, already gave the indication of what the patient had. The patient is, how is the patient now?
Patient is doing well, ma'am. So he's right on follow.
Thank you so much, Nanban. Thank you.
Thank you. Thank you.
Dr. Janisha, if you are online, please, you'll be given the last chance to present. If you're online, please contact us. Next, we have Suresh Kumar.
Yeah, ma'am. Good afternoon. Good afternoon to one and all present here. I'm going to present a e-poster, which is a idiopathic intracranial hypertension causing isolated third cranial nerve palsy. It is one of the atypical rare presentations. I am Dr. Suresh Kumar, currently a postgraduate from Mahatma Gandhi Medical College Hospital. The background of this study is idiopathic intracranial hypertension is defined as elevated intracranial pressure of unknown pathophysiology in absence of any other structural and obstructive lesions. Mainly, the patients will present with a headache and a brief visual obscuration. Here I am going to present a case, a 54-year-old female, a known case of systemic hypertension, came with complaints of headache and drooping of right eyelid for past 10 days. On arrival, patient was conscious oriented, vitals were stable. On local examination, she had right eye ptosis with difficulty in adducting the right eye medially with a dilated pupil of around 3.5 mm. All other cranial nerve examination and systemic examination were normal. All baseline investigations were within normal limits. An ophthalmologic opinion was sought and fundus showed bilateral early papilloma changes, and an MRI brain with MRA and MRV was done. It revealed a feature suggestive of idiopathic intracranial hypertension with no signs of any thrombosis or any infarct. The patient was provisionally diagnosed as a isolated right third cranial nerve palsy, which is secondary to idiopathic intracranial hypertension. Neuromedicine opinion was sought in view of above clinical symptoms, and patient was started on acetazolamide, propranolol, and flunarizine. A lumbar puncture was done with a manometer in situ, and it showed an elevated opening pressure with a 26 mm Hg and 15 ml of CSF was involved, and the CT angiogram was done in view of to rule out any posterior communicating artery aneurysm, and it revealed no aneurysmal dilatation. And patient was continued with acetazolamide, and the headache was found to be resolving trend, and patient was discharged, and the patient was advised to follow. And this is the examination finding. Right eye showed ptosis, and the right eye showed a medial rectus muscle palsy, and fundus showed early papilloma changes with the blurring of disc margin. This is the revised diagnostic criteria of idiopathic intracranial hypertension. In this patient, it fulfills all the major criteria. The patient had fulfilled of 5 conclusions. And coming to conclusion, idiopathic intracranial hypertension most commonly involves the 6th cranial nerve, but in rare cases, it can have an atypical presentation with the involvement of isolated third nerve or fourth nerve cranial nerve palsy or internuclear ophthalmoplegia or skew deviation. Idiopathic intracranial hypertension is a diagnosis of exclusion. So, we have to rule out any structural or obstructive lesions.
Thank you, Suresh. Yeah, thank you, Suresh.
Thank you.
Was there any other drug history or any other comorbidities in the patient?
No, ma'am. Patient is a recently diagnosed systemic hypertension for the past 6 months, and patient is on a tablet amlodipine. She is not a known case of diabetes, and we probed any drug history. Is there any recent scrub typhus fever, like any drug history of doxycycline, anything is there? Because it is one of the cause for intracranial hypertension, but no history suggestive of any recent drug intake.
Sure. And no other symptoms prior to this?
No, ma'am.
No headache, nothing prior to this?
No, ma'am, no prior. Only she came with complaints of 7 to 8 days of fever. Along with that, right eye ptosis. This is the presenting complaint.
Okay. Thank you, Suresh. Interesting.
Yeah.
Suresh, thank you for that presentation. What were the features, the headache that made you suspect that there is something more happening? What were the characteristics of the headache in this patient that you asked?
Yeah, ma'am. This patient specifically told it is a holocranial type of headache, diffuse type of headache was there. Along with that, occasionally she is having some sort of pulsatile headache over the right side. So patient, she is having some pulsatile headache. Along with that, no complaints of any aura symptoms. It initially presented like a migraine type of headache only, she told, ma'am. And then we evaluated for other things.
History can you ask to differentiate between migraine versus an increased intracranial tension headache?
No, this headache, it is not relieved by taking any medications, ma'am. And no history of photopsia,
Go ahead.
blurring of vision, nothing.
Okay, so you'd get early morning headache, worse when their head. That is a couple of things you might get from a drug history. What specific drugs did you ask? Going back from that MRI is saying that it's increased intracranial pressure.
When we ask for any intake of any doxycycline or a minocycline, tetracyclines, most common cause, or any if not pertaining to this patient, if it is engaged now, we can ask for any vitamin hypervitaminosis or oral contraceptive drugs, anything can patient took anything or not, like that we can. Patient didn't have any feel like this.
Thank you very much.
Yeah. Thank you.
This was the last presentation of our session. I would like to ask the judges if they have any final comments.
Thank you, Anuka. I think when we look at studies, we also are looking at obviously the whole concept of what are the aims and objectives, and how can it help a larger group of people? What do you get out of your study? Not just to describe a case, a set of patients, but more to see what the outcomes are and how the impact is into the community at large. Sometimes we do studies, of course, to gain knowledge about disease, but at the very end of it, how it translates into impact on your patient population is what we would hope for. It's difficult in all things. I can see that all of our presenters were trainees, and it's a variable group, but I do appreciate all the work gone into it, because everybody has tried to kind of get to the bottom of what is happening in their patients. But impact-wise is what I would actually mark on. How much does it impact the population you're working with? And that's what I would be looking for. And otherwise, the construction and presentation and other things which we normally look for any poster presentation.
Just to say thank you. I think we enjoyed listening to the presentations. Thanks.
Thank you, Dr. Soumya. Thank you, Dr. Sudha. Thank you to all the presenters. With this, we'll conclude our session.